Hi everyone, my name is Julie Stumpf and I'm a Heart Center Nurse Coordinator here at St. Louis Children's Hospital. I'm joined by two of my colleagues who work with me in our cardiac neurodevelopmental program, Dr. Caroline Lee and nurse practitioner Mary Jane Broge. At our recent Dose of Magic event, we discussed the topic of neurodevelopment and congenital heart disease. Today we'd like to continue that conversation with all of you. So please feel free to send us your questions as you watch and we will get started. I just wanted to say thank you both for being here today. Dr. Lee, can you speak to what the most common complication is after surgery for congenital heart disease?
Sure, Julie. The most common complication after surgery for congenital heart disease, believe it or not, is neurodevelopmental delay and disability. And I think that's something that a lot of people and parents and even us in medicine don't realize. And that's part of why we're doing this, having this conversation today, is to increase awareness, especially to the parents of children with congenital heart disease, to acknowledge to them that neurodevelopmental delays or disabilities are not uncommon in this population, and we want to talk about how to recognize it, what to do about it, and the things that maybe our Heart Center can offer.
Sure, great. And what are some of those contributing factors to neurodevelopmental disability? So I'll start by the preoperative aspects of those contributing factors.
Yeah, so there are a really wide array of contributing factors throughout preoperative period, the operative period, and postoperative, and all throughout life. But what's really interesting, and there's a lot of research that is coming out within the last few years and is still being looked into, is the fetal brain development of children with congenital heart disease. So even before the baby's born, it's been referred to as congenital brain disease in children with congenital heart defects, that there is something different about brain development in utero. So studies have shown that their brains are their brain volumes are smaller, can be smaller, that their maturity is less mature. So, for example, a baby who's born at term at around 39 or 40 weeks gestation, when you image their brain, it looks more like a 35, 36-week baby. So less mature brains even at birth. Differences in metabolism of the brain compared to normal. And we know that certain heart defects have different blood flow patterns to the brain. For example, hypoplastic left heart syndrome babies have just a different flow pattern of blood to the brain than normal babies. And babies with transposition of the great arteries have less oxygen levels going to their brain as compared to a normal baby. So even before the baby's born, there are things going on in development that potentially put them at risk for neurodevelopmental differences compared to normal. And then if you add in things like prematurity or genetic syndromes, and genetic syndromes are found in up to 30% of children with congenital heart disease. Those can be associated with delays. So I think those are some main things, but it's really interesting that even before we do surgery or even before the baby's born, that things are already maybe different than normal.
Sure, absolutely. Thank you. And how about the operative phase? What are some of those contributing factors?
So we have always traditionally have thought that most of the potential brain injury occurs in the operating room. Babies, but that, as I just pointed out, that's not necessarily true. It may be a contributing factor. But most, especially if you're a newborn baby or a young infant who undergoes heart disease, those are considered higher risk than, say, an older child who undergoes heart surgery. But most infants and children who undergo open heart surgery go on what's called a cardiopulmonary bypass machine or a heart-lung bypass machine. And that's so the machine can take away the work of the heart and lungs while the surgeon operates to repair the heart defect. And being on that machine can stir up some inflammatory processes. There are risks of clots and what are called emboli or clots going to the brain that may be small and unrecognizable. So that's one factor potentially that contributes. And then some more complex heart defects require what's called, we call it circ arrest or deep hypothermic circulatory arrest, where the body is cooled so the brain and the circulation are completely stopped for the more complex repairs. And studies have shown that the longer children are on both or either bypass or circ arrest contribute to more delays.
Okay, thank you. And then post-operative, so after they come back from the OR, what are some of those things that could contribute to these neurodevelopment disabilities?
So if any parent has had a child post-operative in the ICU, you know that they're sedated. We want the children to be as comfortable and not remember things, and so we give them sedation to keep them comfortable. So what are the effects of being under anesthesia for the surgery, or multiple rounds of anesthesia for different cath procedures, multiple surgical procedures that some of our children require? Sedation. There can be some hemodynamic instability post-op, where in the ICU there's low blood pressure we need to treat with medications, lower oxygen levels. Then we want some children or infants and children actually suffer a cardiac arrest where their heart stops and requires CPR. Certainly we try and address that quickly to minimize any brain issue. Some of our children go on ECMO or heart-lung support postoperatively, or a ventricular assist device, and there are risks of seizures and strokes, especially in those populations. And then even even if they're off of those things, being in the hospital. What's the effect of a little baby being in the hospital for weeks? Or a child who has to come back repeatedly, and not just in their brain development, but in their neurologic function, but what about their psychological development as well? A young child who needs to keep coming back for caths after a heart transplant, for example. So there are a lot of factors, and I think another important kind of non-medical factor is the family, the parent, the home environment, which as moms we know that we always worry about our children since the day we found out we were pregnant, and that will never stop, but especially if you have a child with congenital heart disease. The uncertainty of the future in general, depending on the complexity of their heart disease, the stress of going through an operation, the financial stresses of being in a hospital and away from work, the effect on the siblings in the family. So that dynamic too contributes to a child's overall development, and frankly just the socioeconomic status too. How much resources and time does a mom or dad have to arrange therapies and take them to therapies and that sort of thing. So that's another important variable. So overall, to sum it up, I've listed a whole bunch of factors, and I didn't even mention cyanotic heart disease, so babies who have low oxygen levels, which is a bulk of our more complex patient population. They have lower oxygen levels than normal, and it can be that way for years. So a whole array of contributing factors, and that's why it should be no surprise then that our children, our patients may have some difficulties in their development and neurologic function along the way.
Thank you. Mary Jane, what can be done to identify neurodevelopmental disability in children with congenital heart disease, both in the hospital, out of the hospital?
Well, I think that, as Dr. Lee alluded to, that we've really underestimated in the past the effect that being in the hospital for a long time can have on these babies. So one thing that we like to do is make sure they're seen by therapists in the hospital and have a good evaluation from birth on. And that's something that in our Heart Center we're really striving to work towards for all our newborns that are admitted to the Heart Center. And then the other thing that we need to do is make sure that when these babies are discharged from the hospital for the first time, is make sure they have an early intervention referral for the state that they live in so that they get therapies as soon as they are discharged from the hospital, because it is a long process to get these therapy services started. And then the most important thing that we can do is listen to the parents. They know their babies best from the time that they are born. They are their advocates, and what we can do is listen to them, and they know when something's not right from birth all the way through the rest of their childhood. And so the other thing that we like to encourage parents to do more and more is to hold their babies that have congenital heart disease to the same standards that they would a baby that doesn't have congenital heart disease, because we know that they can have a really good quality of life if we can catch developmental delays early and then intervene upon them with early therapy, service referrals, or referrals to whatever else that they might need.
Great, thank you. And Mary Jane, can you speak to some of the difficulties or delays that parents should be aware of when their kids, start either in the infancy, toddler stage, or starting preschool?
Sure.
Thank you.
Yeah. So I think that most of the parents that have been had babies that have been discharged home from the hospital, the two biggest delays that we see are difficulties with feeding, and then difficulties with gross motor, not rolling over in time or on schedule, and then really eating is such a huge struggle and such a burden, I think, for some of our families, and something we're really trying to work on getting a hold of early and getting as much therapy as possible for them. The other issue that we see a lot of is issues with sleep. They come home from a long hospitalization and in a very noisy ICU and floor environment, and then they come home to this quiet house, and there's a lot of issues, and parents are understandably so afraid to let their babies cry, and they're not monitored constantly anymore, and so that just leads to a lot of sleeping difficulties. I think that as the babies get a little bit older, one of the more common things we see in infants is language delays. So it seems that that a lot of our babies and infants, toddlers, understand what they're saying, understand what we're saying, and understand what parents are saying, but they cannot express things themselves, which can lead to a lot of frustration, not only for the parents, but also for the child. And then behaviors come out of that with anger and frustration and aggressive behaviors. And then as far as preschool goes, that's when we're starting to get to a little bit higher level of functioning. And so handwriting,
Fine motor
skills, become more difficult for these kids.
Okay. Dr. Lee, can you talk a little bit about the school age population and adolescent and some of those delays that parents might want to look out for?
Yeah, so in the school age, so I think a lot of times maybe in kindergarten, children might be able to get by, or although some don't in terms of behavior, being able to sit still. So, and then especially as kids get older and enter the elementary school years, and the demands become a little bit more in terms of skills such as writing, but processing information, listening, looking at the board, writing, remembering their homework, those type of executive functioning, being able to take in a list of directions and follow through sometimes can be a challenge. We know studies have shown that children with congenital heart disease are at increased risk for inattention. So things like attention deficit hyperactivity disorder is not uncommon in our population.
Interesting you bring that up. We had a question from the audience in relationship to ADHD and medications. Any contraindications with congenital heart disease and taking those medications?
Yeah, we get that question a lot, actually. We get a lot of questions both from pediatricians and psychiatrists who want to prescribe the meds, and also from parents. There's, in general, my impression has been there's been hesitation or a fear about those medications, but actually, on the contrary, I think we realize that many of our patients may do better with medications to help them focus. They'll feel better about themselves. Their performance may improve in school. So I think it's definitely something that should be discussed with the cardiologist. Most of the time, there are not real contraindications, meaning no reasons why a heart child should not be on or could not be on, but some who have different types of arrhythmia type of issues that may warrant more thought or more input from the pediatrician. But I would not be afraid of the medication. I mean, a lot of children in general need some extra help in that way. And so I think parents, I hope, would be open to it if it may make a difference. And there are a whole variety of medications, and I can't speak to which is better. And I don't think any of us know of any particular med or class that is better. We defer to the pediatricians and the psychiatrists for that. But I think as cardiologists, we are open and expect and welcome those questions if that's going to help our patients, especially in the school setting.
Thank you. Mary Jane, can you speak to some of the resources that we here at St. Louis Children's can offer families if they have questions in regards to neurodevelopment, concerns?
Sure. So I think that even starting from a prenatal diagnosis, we have a really great perinatal behavioral health program that we try to refer all the prenatal diagnosis families to. And from there, they really can build a relationship with these moms and dads and get to know them. And from that aspect, it can help the family dynamics and help the parents cope with this a potentially long hospitalization.
Can I just speak to that since I am in the fetal heart program and have we make diagnoses of significant congenital heart disease, and this perinatal behavioral health is a psychologist who helps and meets with our pregnant moms, and we know it's very understandable for expectant moms who are carrying a baby with heart disease to feel overwhelmed or sad about the diagnosis and the loss of a normal pregnancy, and anxious about what's to come, and so we want to be proactive, and those coping skills you refer to, I think are important as early as possible. We need to teach our children that too, but as parents of heart children, and a relationship between mother and father or caregivers, and how to best have a best dynamic in that setting. I think addressing those issues early on hopefully will help set the stage or pave the way for what's down the road for their family.
Yeah, that's great. And then I think starting in the ICU, in the last year in particular, we've really tried to shift our culture and shift our frame of mind into what we can do starting from the moment these babies are admitted to our heart center in order to help them. And the kind of logo or mantra that we've been saying is not just to survive, but to thrive. And we want these babies to have the best quality of life that we can give them starting from the beginning. So in our heart center, we're really looking at things like early feeding, proper positioning, kangaroo care, letting parents hold their babies as often as possible, little things that really can add up to make a big difference in the bonding that goes on between parents and baby, and then can actually hopefully even decrease the amount of medications they need for sedation and pain, and then maybe even get a quicker discharge out of the hospital. So that's.
Can I stop you real quick,
Sure,
Mary Jane?
yeah.
You said kangaroo care. What specifically does that entail?
So kangaroo care is skin-to-skin care with mom or dad holding the baby up on their bare chest. It's very common in NICUs with premature babies, but it's really something we haven't done in our heart center. We've been nervous about the lines and tubes that these babies have. But with the research coming out about how their brains, even if the baby's born full term, their brains really are a premature baby's brains, really think that it can benefit the babies if we treat them a little bit like preemies. And I think it's been really valuable for the moms over the last year to get to hold their babies and get to have this special moment that they probably got taken away from them in the delivery room.
So even babies with breathing tubes.
Absolutely.
And lines and
Yes.
monitoring.
Yes,
You put those babies
we do.
skin to skin with mom.
As early as possible, and dad too, if they would like to. We have pretty few limitations as far as what babies can be safely held and do kangaroo care.
That's great. Thank you.
And then from going from there, then we kind of shift our focus to the outpatient, and we have an amazing, if I do say so myself, cardiac neurodevelopmental program that started about 2015. Our clinic we have a cardiologist, which is Dr. Lee, and then myself as the nurse practitioner, Julie as the nurse coordinator, and then we have a neurologist, newborn medicine, and then therapy services, physical therapy, occupational therapy, and speech therapy, a psychologist, a dietitian, and then social work if needed. And we see these babies hopefully within the first 6 months of life. And really, it's just a multidisciplinary look at these babies to see how they're doing overall, not just looking at their hearts, but looking at them as a whole person, and also looking at the family dynamics, and to see if there's anything that we're missing, if there's any gaps that need to be filled in their care, to make sure that they're receiving the optimal therapy that is for these children. On top of that, we do formal developmental testing for kids really at all ages after the age of 1. And that can really help with driving their home therapy programs. So we can look at them based on a standard against all other children and say, well, you're a little behind in this area, so we really think you should start physical therapy or increase your physical therapy to twice a week. After the age of 3 or 4, we have neuropsych testing, which really helps to look at these kids as they get ready to enter school. And that's a new addition that we've had over the last several months, and I think it's really going to be really life-changing for a lot of our families. And then the other thing that we do, I forgot to mention, is that we will help with individualized education plans after the age of 3, when they have to transition out of that home care and home therapy into a school system. And so we really try to be proactive as far as helping those families starting at about 2.5 get ready for the transition so that there's no gap in the care that they receive.
And our clinic is really full. It's
Yeah.
just once a month, and we're trying to expand that, but because we're starting with just about every baby who leaves our hospital after open heart surgery especially, or if they've been had a heart transplant or had a complex stay, those get referred. And so even just our baby population alone, it keeps us quite busy. And I think the point about follow-up, it's not just a one-time thing, but we do want to follow because, as we discussed earlier, different issues can emerge as the child gets older. So I know we recently saw a baby, a child who had been developing okay, but then on follow-up had some regression, and so we had to modify their therapy recommendations. So follow-up is important, but I love clinic in general, my cardiology clinic, but I think the neurodevelopmental clinic is a joy also just because it gives a real full look at the baby or the child, I should say, in the context of the family life too. So I love that we're able to have help with sleeping issues, like you mentioned, a baby who had 2 heart surgeries, and mom and dad understandably were afraid to let the child cry out. And with the cardiologist's perspective and the psychologist's help, we're able to kind of wean that process so the baby could have better nighttime sleeping. So very practical things about sleeping and eating issues, feeding. As you mentioned, feeding issues can be a big time and energy consuming endeavor for families, and so quality of life more than just the cardiac defect and the cardiac status.
So all of this can be really hard for parents, navigating all of this. What advice do either of you have for parents with a child that has congenital heart disease and kind of getting through these difficult times or times that could be pretty difficult for families?
I would say I think an important message is that we know these issues occur in our patients, and we're learning more, and the shift there has been a shift in our field of pediatric cardiology and cardiac surgery, where we were always, the papers, the medical literature was written about survival outcomes or reducing morbidity, meaning lessening the time on the ventilator or time in the hospital, length of stay, and those type of things. And there really is more of a shift towards quality of life and longer-term outcomes. So I think that's exciting, and I think that is very family-focused and centered. And I just want to encourage parents and to affirm that these issues may occur, and not to feel alone or that it's unusual or your child is the anomaly, and that we as a heart center want to try and help address those. and that you should talk about it more. And as a cardiology group, we don't talk about it enough, I don't think. Our focus is getting the echo, the EKG, Holter monitor, whatever, pacemaker checks. But how is your child doing in school, and how are they getting along with their friends, and what hobbies do they have, and those type of things, I think should be a focus too. So I'm speaking for my group of physicians, and that we should address those. I think those are just as important, sometimes even more affecting the everyday life of a child or family life than their actual heart condition. So I encourage families to, if your physician, either your cardiologist or primary care physician, doesn't ask about those things, to volunteer those things or to ask for help. So I think that's a big message.
Thank you both for that really important information. I think it's really beneficial to families to hear all of this. Are there any questions from the audience for Dr. Lee or Mary Jane? All right. Well, thank you all for joining us today. We hope you found this valuable. Please don't hesitate to leave a comment below if you have any questions. We'll be sure to answer it. And also mark your calendar for March 14th, where we'll have a discussion on navigating throughout school and advocating for your school-aged kiddo. So thank you again, and we'll see you next time.